preliminary outputs and lessons learned from early adoption of LAN from the 4 out of the 9 early adopter countries, as I've already mentioned. Right, so this makes this session special, as I've said. We'll also speak about innovations, including HIV self-testing with land service delivery in Mozambique, and also the use of innovative AI tools for reaching rapidly the people with innovation, with information that will be from South Africa, and driving demand for PrEP and LAN from both South Africa and Zimbabwe. So I would like to now call out our first speakers. We're going to have this session cut in two. We'll have the first three speakers, and then we'll have 2 or 3 questions, and then we'll have the rest of the speakers and another Q&A. And our first 3 speakers will be from Eswatini, Zambia, and Mozambique. Let me call on Cindy Nana Mate from MOH Eswatini. They'll be talking to us about first in Africa Lenacapavir development, Eswatini's early implementation service evidence. Over to you, ma'am. Can we please? Great. All right. Next one.
Good morning, everyone. I'll be taking you through our experience as Eswatini. We really appreciate the opportunity to share our experience in the early implementation of Lenacapavir. May I have the next slide, please? Sorry, just up. It's falling. Next slide, please. So as Eswatini, we have a high HIV incidence, which we have recorded amongst the young women and also the adolescent girls. We are still above 1% when we compare to our males. And we've committed to the introduction of PrEP ever since 2017, when we started introducing oral PrEP as demonstration project, and we scaled it up in 2019. Recently, in 2024, we introduced the cabotegravir and also the PrEP ring, following the pilot which were done in 2023. And recently in 2025, that's where we launched our first Lenacapavir, and we are currently implementing in few selected sites following that launch, which happened on the 1st of December. Next slide, please. And we really appreciate the leadership of the Minister of Health for taking that decision to introduce LAN as an additional PrEP product. In terms of the preparations, it included different areas which we needed to work on. First of all, we had to update our PrEP guidelines to incorporate the LAN and also the recommendations that have been made by WHO. And since we introduced the cabotegravir and the PrEP in 2024, we developed an implementation plan, which, as we are incorporating the LAN, we also had to review and update based on the incorporation of the LAN. In the implementation plan, it includes some core areas, which include the policy environment, the budget. It includes also the service delivery, the human resource, and pharmacovigilance and monitoring and evaluation, and also the part of the demand creation. And as a country, I think we are, in terms of working on our systems and also the supply chain, which is part of the implementation plan, we had to work on our quantification and forecasting, where we considered the performance of our PrEP in general, looking at 2024. We also looked at our quarterly targets, where we made assumption in the introduction of LAN in terms of the initiations, in terms of switching, and also to look at how many sites can we start with. We will be using a phase-out approach, where we had few sites which gradually will be increased over time. We also considered the commitment by Global Fund in procuring of LAN, and then we requested the gap from PEPFAR. And our quantification covered a period of 5 years. So the last 2 years, they will be covered by the government, where in the first 3 years will be covered by Global Fund and also PEFA. And what we've also done, it was to update our PrEP module. Majority of our facilities in the country, they're in the electronic health system, which is client management information system. So we also had to work on that one. Next slide, please. Then on the provider capacity building, we've conducted some trainings. We started by updating our training material, as we have been using them for the other PrEP options. So we've just updated, and we've conducted a master training of trainers who are expected to conduct on-site training of those facilities, as I've said, that we'll be introducing in a phase-out approach. So for the first sites, we have 5 sites which have been targeted, who are benefiting from the 500 consignment that we received as a country for the launch. So those sites have been trained. That included cadres such as nurses, HTS counselors, pharmacists, and we also have the community who are creating the demand at community level. We're also trained. What we can say is that our IPs, they'll be the ones moving forward as we introduce to do the on-site trainings. Next slide, please. So this is what we gathered ever since we introduced the LAN from the community themselves. They were really excited for the country to have made the decision of introducing LAN. And some of the verbatim that we've captured, they are saying that they are excited because of the efficacy and safety of the product. And the less frequent visit, as you know, that we've been implementing the oral PrEP, where we are expecting them to come monthly, every 3 months, also with the ring, and then the KBLA every 2 months. So they were really excited with the 6 months. And the fact that it is discreet, we know that there are a lot of issues when it comes to the negotiation with their partners. And what we've also observed as we're engaging, they've indicated that we have to emphasize the issue of LAN being not a vaccine, because that was those were the news that were circulating, that there is a new vaccine for HIV prevention. And they have emphasized that we have to make sure that people, they get the right message, which is also very key. So you can tell that people are really preferring the LAN over the taking of the pills every day. Next slide, please. So this is the data that we have. We have 2 sites that are active at the moment, and we've been able to enroll about 58 clients on LAN ever since the launch on the 1st of December. And this is the disaggregation. Majority of the clients that are taking up the LAN are coming from the AGYW, as you can see. So 74% of the initiations are females. And we are happy to also see some men taking it up. We know men with injections, they really they have challenges when it comes to that. But we are happy that we are seeing men taking it up. Please click again. Also, we have seen that there is a lot of switching that has happened. Almost 50% of those that were initiated, they've switched from the 3 options that we are currently providing. Majority were coming from the oral PrEP. And we really appreciate that there are people that have never used PrEP that are also took the PrEP. I think the last one is just the disaggregation on the performance of the sites. The next click. Yeah. Then what are the lessons that we've learned as a country? There is really a need for countries, if they will be implementing, to start working on your policy document, because it really takes some time. So that's what we've seen, and be flexible, because there are a lot of modifications that happens along the way. And it's also important that we create that confidence amongst our healthcare workers by providing the trainings and also providing the mentorship. Also investing in messages, as I've already highlighted, that there is a lot of confusion. Even those that are on ART, they are now thinking that they are going to benefit from the LAN. So it's very important that we dispel all those misconceptions with clear messaging, and also to monitor what is happening in the media space. Next slide, please. Then there is also a need for rapid reporting channels, so that we can be picking any adverse events. Next. and then reflect on the experiences of these few sites so that it can inform our scaling up or our additional sites as we continue to add more sites. And then lastly, it is important that we balance the counseling. We still have to make sure that LEARN, it is an addition to what we've been providing, and it's not coming to replace the condom usage. We've seen with PrEP, there are issues with the usage of the condom, especially since we've introduced the PrEP products. So with that, I would like to thank all the partners that have really supported the program. We have Global Fund, we have SIF, we also have PSI and CHAI and Kango, who are in the community. We appreciate all the support that we've had as a ministry. Thank you so much.
Thank you, Cindy, and congratulations to Eswatini. Lessons learned, lessons learned. This horse has bolted, and it better leave no one behind. Trust me to talk about horses, those who know. Anyway, the next speaker is Dr. Chimika Piri from MOH Zambia. Dr. Piri will talk about long-acting injectable PrEP Lenacapavir implementation. We'll hear about the Zambia experience. Doctor?
Thank you. Good morning. I feel honored to share with you Zambia experience. As introduced, I lead the HIV prevention program. Next slide. Next slide. Next. Yes, so as a country, we've managed to reach the UNA's 95-95. However, we still have a gap in other subpopulations such as children, and also we are still recording quite significant annual new infections. So it's one of the areas we still have to work hard to reduce to less than 15,000 as our national target. Next. Yeah, so in terms of a PrEP journey for our country, we introduced PrEP as early as 2017 after WHO produced the guidelines. And over the years, we also, we did scale up the oral PrEP until 2024 when we introduced the long-acting cabotegravir. And I want to mention that Zambia is one of the countries to implement after the start settings, and we've done so well. And because of that experience, it has been easy for us to introduce any new HIV prevention tool such as Lenacapavir. So this year on 1st December 2025, we launched the Lenacapavir, and we're just slightly a few hours behind Eswatini in terms of injecting. Thank you. Next. So in terms of the activities that we had prepared to leading to the launch and post the launch, as I mentioned earlier on, in terms of the health systems, we had, I think, already established based on the past experience of introducing new tools, and this made it easy for us, even as we brought in Lenacapavir. So quite a number of activities, including updating of our policy guidelines, that is implementation, and as well as PrEP guidelines, and also looked at product registration. And I must say that within 2 weeks of the Gilead filing for registration, we did manage a record of within 2 weeks. The products were registered in Zambia, and we were second from South Africa in Africa. And other activities, as we shared, most of them we actually managed to complete within targeted time. So one key activity was demand creation, and I think it has really helped us in terms of ensuring that there's adequate awareness across all populations. Next. So further, we had other activities that are ongoing, such as training and as well as provision of on-site technical support and mentorship. Next. So just highlighting in terms of the support as a country, Global Fund is supporting us for 22,000 individuals in year one. And just a few days ago, PEFA also came on board, and they are going to support us with the 60,000 individuals in the same FY 2026. So we're excited as a country, looking at the numbers, and I think so far, so good. This has been possible because we are working close with all key stakeholders, including the CSOs, and also we have a very vibrant PrEP technical working group. Next. So it's just highlights in terms of the pictures of what we did on 1st December, the World's AIDS Day. As you can see, there's a um, our honorable minister seated there, and also in the mid at the bottom there, that's me, and the first recipient of injectable Len, we call him Mr. Len. And then if you see very close where there are balloons there, inside there was a queue of individuals waiting to receive Len. This included pregnant women and as well as breastfeeding women. Next. So in terms of quantification, we did actually using PrEP2 as a country. Based on the 22,000, we used the 2 and just to produce the output in terms of the initiations, continuations over the next 3 years. And so it just shows in terms of the gradual scale up. Next. So the output, this will be revised because now we have further 60,000, but this was based on the 22,000 that Global Fund committed. So we are looking at scaling to, introducing the lane in 159 sites in across 52 districts of the 10 provinces of Zambia. And then this will be done alongside the other existing PrEP, oral as well as cabotegravir. And we have a target of initiating about 410,000 individuals in year FY26, and majority of them will still be on oral next. So in terms of looking at the number of individuals we intend to provide Len, we want to take the services closer to the community to increase access, and doing that, we are looking at demedicalizing the PrEP services in our country, where we want to engage the private sector, private pharmacy right in the community, so that people really need to go to the public facilities for them to access PrEP. So we are working on the implementation framework in terms of, because there are some legal issues that we need to address before we start this, and also looking at the possibility of integrating it into family planning, because currently we have community health workers that are providing injectable family planning right into the community, and want to see how we can integrate PrEP and not just Len. And across it, we want to ensure that we enhance the health, M&E systems. Next, I think this was my final slide. Next. Thank you for your attention.
Thank you once again to Zambia. We will have Dr. Pedro Antonio from Missão, Mozambique, talking about innovations for Lenacapavir introduction and scale.
Okay. Good morning for everyone. I'm Pedro. I'm sharing Mozambique experience of innovations for Lenacapavir. You can go to the next slide, please. Okay, next. Okay. Oh, our map of our country disappear. I don't understand why. But okay. That's okay. I remember all the information. Yeah. Mozambique, it's gonna start to implement Lenacapavir next year, and as part of the plan, as you see, we have 92,000 of new infections annually, and in these new infections, we have 37% of adolescents and young people, and the rest of the infections come from the children with age under 5 years and the K populations. And looking for the offering of PrEP, we offered in this year about 306,000 people PrEP, and we are offering PrEP in 44% of our health facilities. We are talking about 800 of health facilities that we offer PrEP all the forms of PrEP. We are talking about the oral PrEP and the other forms of PrEP, like injectable and the vaginal ring. And for this next year, we are receiving doses from the Global Fund and from the PEPFAR. It's about 46,000 doses on general. And has a decision, we have to offer this dose of lenacapavir for the group of people that needs this intervention. And we decided that all individuals that are eligible for PrEP can receive the lenacapavir, because I already explained it, which groups are important from Mozambique to offer the PrEP, looking for the new infections. And we are planning to start this intervention in the March, and the first dose of lenacapavir are arriving in the country by January, and the site delivers places. We are, I'm going to show you in the next slides. Uh, Again, I don't know, maybe they don't want to see our country maps because I can see here in my papers. Uh, okay, the next slide. Okay, this one. Okay. We decided already who we're gonna offer the lenacapavir. Now we have to decide to show how we decide which place we're gonna offer this intervention, and we decide to look on 8 strategy indicators where that we define it to make the geographic prioritization for the introduction of lenacapavir, and which percentage of weight we proportional to this epidemiological and programmatic relevance. And you can see that new infection and incidence of HIV were the principal indicators. Then you come with the people that tested negative, because they we know that eligible, they are eligible for PrEP. And we see the people that already are in PrEP for initiations and for the total PrEP, because we want to offer the intervention in a place that we already have any experience of offering this PrEP. So we are not starting to offer lenacapavir in a place that we never offered even oral PrEP. And then we look at for the importance of the K population to define the indicators. In the K population, we focus on the information about the PrEP that we already offer for this K population, the HIV negative test, how many people we can find, and the positive people that are K population. And then we are looking for this. We decide to implement lenacapavir in 5 provinces. And in these 5 provinces, we are going to start in 3 provinces that are Zambezia, Maputo, and Maputo City. They they were defined, and we are covering 21 districts and 86 health facilities. So we are under the process to finish the defining of the remaining 2 provinces that are Nampula and Gaza, that we have to finish the definition of the districts and the health facilities. Okay, so looking for our readiness, we developed a implementation plan for lenacapavir that was already approved and present to the donors and for the other important intervention. So we developed 2 implementation plan detailed with the information of the key activities and the responsibilities and the operational target. And we included the information of lenacapavir in our national combination HIV prevention guideline that's to be launched in January of next year. And looking for the regulatory information. So the local imported company was identified and communicated with ANARM, that is the institution that it's responsible for the registration of lenacapavir. And we are treating the process of special importation to be more quick to have the product inside our country. And ANARM now it's on the process of registration on lenacapavir based on the information of pre-qualification of WHO and of the information of South African registration, because it's part of our process. looking for the information about the facility level implementation. As you can see, we already decided in which places we are offering Lenacapavir for the first 3 provinces. So it's missing just 2 provinces. We are finishing our package of training already, and we have already done the site assessment tool and checklist already finalized. And the TOT for Lenacapavir is going to happen by February of next year, and land registration tools and SOPs will be printed for the provider to use. Looking on demand creation, I think that is the most important thing to do when you think about prevention. Our midterm evaluation shows that there's a low literacy on PrEP information on our country. That's why we're having 2 campaigns. The first one is about PrEP on general, that is to be launched by January. And the another campaign is about Lenacapavir that we are launching by March of next year. And these campaigns, we are using materials developed by WITS. We just updated the information for our contest. And we are planning to use the digital technology solution like chatbox and others to increase the PrEP literacy for demand creation. And our monitoring information like indicators cascade are in process to be launched. Looking for the intervention of prevention, one thing that's important is to simplify, and we have to start simplifying. Zambia told us that they are simplifying looking the intervention in the community, and we started to simplifying looking how we can simplify testing. And what happens is that looking for our information about testing, we see that implementation of community-based HIV self-testing to increase HIV diagnosis among key populations and population that are vulnerable. Our survey in 2021 shows progress on the achievement of the first global target, but we have just 71%, and then we have to develop a plan to accelerate how we can uh, uh, how can achieve this first goal of the global information. So to achieve this first goal of 95 first 95.5%. What we have done is that we have to we started offering self-test in Now Ajuda health facilities in Nampula province. And we defined that because we want to increase the HIV testing in health facilities with high HIV prevalence, and where more than 5% of people living with HIV are unaware of the HIV status. And then we thinking about introduction of the simplified streaming algorithm that now have just the normal algorithm have more than 10 questions, but now the algorithm that we are using have just 4 questions. And the first question is, you know what is your result. If you don't know what is the result, you just get tested. And if you know the next question is when you tested. If you tested a long time, you have to test again. Just 4 questions that are simple questions. And then we introduced the health facility-based self-testing to high client volume health facilities and those with low HIV case identification through conventional testing. And as we see in the results, we are comparing 2 different years. We can see an increase of HIV testing uptake in intervention when we compare the self-testing and conventional testing districts, and we can see 2 things. First of all, we see that there are high volume of HIV self-testing that were distributed, and that demonstrates that there is a good acceptance of HIV self-testing approach in the health facilities. And we can see too that even with conventional tests in the health facility, when we simplify the algorithms, during the pilot, we can see the increase of people that we are already testing. And because of that, we think that we can uh, think about introducing self-tests for PrEP. For PrEP, for continuation, we are already doing that. But we are thinking to introduce self-tests for initiation for PrEP and for Lenacapavir. And we want to do this because we want to address the missed opportunities of HIV tests at the high client volume health facilities. We want to increase the HIV diagnosis among people living with HIV that are now aware of their status, and we want to create demand for PrEP among clients who are tested or who tested HIV and they are negative, and we can evaluate the acceptance, feasibility, and the effectiveness of self-testing with Lenacapavir service delivery for our country. So that's what the information that we got to thank you.
Thank you, Doctor. We're going to have like maybe 2 minutes. I'm hoping that other countries are here and we're taking notes because we're learning and learning. And maybe 2, 3 questions before we move into another session. Any hands? Sean, and then you, sir. Okay. And then the last one. Thank you. And just state who you are and then who the question is addressed to. I'll give you a mic now. Turn it on. Turn on the mic. There's another one.
Hi, folks. Sean Malone with PSI in Johannesburg. Your role for the various products, and how are you thinking about that in terms of cost and cost effectiveness in particular?
Let's have the next one. Here. We had the question, right?
Thank you so much. Putungwepe from South Africa. I just want to find out, especially from Zambia, they've mentioned that they're going to be integrating, or rather, forming collaboration with the private sector, just to see the modality of that. I want to find out if they've managed to do that so far, and also just to find out if there are any other planned community-based delivery models that they have thought about, apart from the private sector engagement, such as your faith-based organization, NGO sector, all of those different modalities. Thank you so much.
Thank you. Last one. So at the back.
Thank you. Thank you to all the presenters, and great lessons for us all. I am particularly interested, and first of all to Zambia, just to say well done for getting it out into the community. I heard about integrating with family planning injectables, which is really a great move. So thank you for that. My question is around vertical transmission prevention. I wanted to understand what you're seeing in your countries, although I know Mozambique, you didn't mention pregnancy in your presentation, but I wanted to understand what you're seeing around uptake of LEN in pregnant women, and if there's any hesitancy, what you think some of the issues might be, so we can all start to sort of think around that as we implement in our different countries. Thank you.
Let's have brief responses from the panelists or presenters.
Okay, thank you very much. I think I will respond to the issue of the PrEP choice counseling. That is very important. As a country, as we're updating our guidelines, we have made sure that there is a provision the guidance for the healthcare workers to always provide a PrEP choice counseling ever since we started expanding the option. So even with the LAN, they are also expected to do the same so that our clients can make an informed decision. So it's also very critical that beyond the guidelines, you need job aids that will actually guide them on how they engage. And even in the community, as they engage the peers, they also used to say, they are expected to use the same approach where we are talking of PrEP choice counseling to inform the client for informed decision on whatever that will work for them in terms of addressing their needs and also their situation. Thank you.
Thank you. I will comment on the private sector engagement as well as the cost and cost effectiveness. I think there's a question around this. So as a country, Zambia, moving forward, we are looking and prioritizing ways in which we can deliver the services, of course, maintaining the quality in a cost effective manner with the sustainability in mind. So there are a number of approaches that we are modifying as much as we would want to make sure that services are brought closer to where the individuals are. So we identified some of the models that as a country we feel that were much supported by donor, which we feel as a country we may not be able to sustain and want to modify them, such as remember DREAMS, DIC models. So we want to see in terms of we remove certain costs, maybe by identifying buildings that belong to government and renovate it so that we don't pay rentals and the like, and then second government staff to working there, but of course partnering with the IPs. So I think that's what we are looking at in terms of ways. We haven't done the modeling in terms of which of the prevention tool will be more cost effective, but that's the angle we are looking forward to, because we cannot manage resources to provide all the available PrEP options, but we want to see in the near future in terms of which ones will be more cost effective and impactful. And in terms of community activities, yes, we have, as I mentioned, currently family planning. I think they've done well in terms of use of the community health workers. So we want to see in terms of how can the country allow land to be, and other products be delivered by community. There's a lot that needs to be done, and also to engage the community pharmacy and public clinics, private clinics. So because the feedback I've gotten so far is that individuals don't feel comfortable coming to the facility because of congestions, and they are okay, they're not sick. So they'll prefer something somewhere where they can walk in anytime and then access the, and indeed we've worked very well with the faith-based organizations, which are there's a organization called CHAS that Global Fund is supporting. So government and these mission hospitals has worked, our faith-based organization have worked very well in delivery of other HIV services. Thank you for that comment in terms of integration of family planning. I think I'll end here. Thank you.
Thank you. Prevention is about choices, and PrEP is about choices too. So for some province, we have the opportunity to give these choices for peoples. Like we have in the same province, Lenacapavir, we're gonna have Kabele and oral PrEP. So people can choose which intervention they need to receive. Looking for the interventions of PrEP on the community. For our country, we are using the community to create demand now, but we are starting discussions to look how we can move the intervention of PrEP from the health facility to the community, because people say to us that they are not sick and they don't understand why they have to go to the hospitals or health facilities to have this intervention. So we are thinking about how we can do that, and don't miss the information of how we have to collect the information of this intervention. And looking for the last question about the intervention on pregnant women, was a issue when we think about that, because the first information of Lenacapavir, we were told that we are offering this intervention and this injectable PrEP we are offering in the belly. And has, you know, cultural information on Africa, when you offer some intervention in the belly and the baby is there, and if something happens to that baby, they're gonna connect already with the injection that we already offered these persons. And we discovered that we can offer in another areas of our body. That's why for this group, special group, we prefer to offer not in the belly, but in other areas of the body, and for to avoid this issue of thinking about which cultural impact we can have with this injectable PrEP on the belly. Thank you.
Thank you very much. I'll hand over to.
Thank you so much. A lot of really exciting data and updates this morning. It wouldn't be a conference in 2025 if we didn't discuss AI. So our next two presenters will be speaking about the power of AI technology to increase knowledge, demand, and uptake of PrEP, including Len, starting off with Tombafikile Mchale from Shout It Now, South Africa. So welcome.
Good pronunciation, Zach. Well done. It might be easier for me to click my own slides, so I don't know if that's going to be possible. Not possible. Okay. You'll have to be very interactive with me. Firstly, I'm very excited to be able to share our experiences on how AI can drive demand for PrEP, as well as learn based on our early intervention implementation experience with AI tool designed for adolescent girls and young people. Next slide. So recently I was reviewing the data and I found this quote which says, he refuses to use protections and tells me if I'm clean, then he's also clean. And is that true? And we also know that this is something that happens all the time. This is a young woman who asked this question to her private AI companion. And you can imagine the fear, the shame, and the confusion that she had at that time. But her companion responded by calmly shutting down the boyfriend's accession and pivoting her to offer HIV testing and protection. The chat went on to help her to get a self-test. Click. This exchange happened on an Order's. We need to move. The exchange happened on Order's self-care from anywhere platform, which is being delivered by Shout It Now in South Africa. At its heart is Amy, which is an AI companion and modular AI system that builds trust, personalizing support, and connects people to stigma-free care. We are tailoring versions of the platform for different audiences, as you will hear today, to learn what works, what doesn't work in extending access and driving demand. Click. But just like consumer apps like Instagram, they tailor ads that seem to know you. We are also taking the same logic and basically applying it more ethically for health. We've completed about 7 months of data collection and the early signs are promising. But what is the problem that we're solving? We need to move the slides. So just stepping back, what problem are we solving? For many, especially youth, it's firstly access to trusted, accurate information is very scarce. We know this. They go to different platforms, ChatGPT, Google, Meta AI, but they hit walls of vague and inconsistent answers, as well as shutdowns shutdowns on sensitive information. Also, there's demand for guidance. Young people and many people are actually craving good, credible information, but we know that the supply of human support is shrinking and that human trust can't always be scaled. So our goal is basically to be able to fill that gap. So this is not just a chatbot, it's a demand generation strategy designed to spark agency, trust, and uptake at scale. So the question would be, what drives uptake of revolutionary biomedical intervention? So we see 4 factors. Firstly, it's information. People need accurate facts delivered in the language that they understand and when they are ready to hear it. Second is insight. It's not enough just to know the information. They have to also see themselves in the vulnerability. Thirdly is the intervention. When the light bulb goes on, we need to be able to illuminate the path to the options and make it simple for them to act. Finally, and most importantly, perhaps, is trust. None of these above factors matters if people don't trust the source, the system, or the path to care. So that also depends on our ability to understand and address the barriers that people face in terms of testing, disclosure, as well as connection to services. So these 4 quotes are from from 4 young people, real women in South Africa. I would like us to take a look at one of their journeys. And this is a young woman who was unsure where to turn to. She asked Amy for help. Over the course of several conversations, and the AI chat is on the blue, and the orange is actually when we start having an intervention from a human clinician. So she's then guided through these key moments, and at the end of the journey, she messages Amy and she says, "I went and got PrEP. I'm feeling much better. I feel like you've pulled through for me." That's what's powerful here, is not just the outcome that we are seeing, but the trust that was built through each of the steps. And this kind of demedicalized, stigma-free spaces, they really it surfaces real needs of the people, and it also acts as a frontline triage tool, enabling clinicians to really be care while ensuring that no one actually slips through the cracks. So what you are seeing here on this particular slide is very difficult without me clicking the slides. What does it really look like in practice? So you're going to need to go back a little bit. Firstly, at the information, the AI companion is available 24/7. It uses a combination of large language models. It has a contextual knowledge based, a slang dictionary, and a longitudinal client record that lets Amy respond with continuity and care. So it doesn't ask you every single time what the problem is, because it's chatted to you and it remembers some of the conversation. So as a client chats, we are able to also pull a vulnerability score in real time. And right now we're using validated traditional HIV risk tools. We've also developed a precision model for LEN in partnership with Philaxis.ai, using social determinant of health as a starting point. But here's a nuance. Somebody who's asking for PrEP already has insight about their own vulnerability. So the vulnerability score is not a gatekeeper, it's a guide. So these scores and these signals drive the flow of the conversation, firstly, and they direct clinicians on where and when to engage. So we see a guided HIV self-test right at that corner, and the result is being uploaded. We have a computer vision which then confirms the test result, even if the line is faint. Then obviously, if there is a misinterpretation between the client, what the client is saying and what the computer vision is saying, it prompts a nurse to be able to, a clinician to also be able to respond. So what happens on the other hand is that a clinician gets the support, including the summaries of the conversations from Amy and the client, the verified test results, as well as a vulnerability score. That then gives them a full picture of on how to provide responsive and relevant care. But how do we know this actually works and that clients do trust it? We see that over 30% of the clients come back in the next month to ask more questions. So what I also want to just underscore here is that the real power is augmentation for humans in the loop, not a replacement of human. But also we know that from the supply side, we have to ensure that when clients are showing up more informed, more motivated and ready to act, they need to ensure, we have to ensure that the healthcare workers are able to meet them where they are. So we have tools that empower them in terms of training, support, and as well as quality assurance tools. Now, our first big question, like I've indicated, please just stay on this slide. Our first big question was whether people would share deeply personal information and experiences with an AI companion. We found that obviously that yes, they are open to chatting about whatever is on their minds, and that's what's important. But what the AI tool is able to do is gently guide them back to a focus on health. So the results, what we are seeing as indicated, is that people come back to the chat. We'll also see that when they come back, when they start with a topic, that jumps up to about 50% when of the engagement. And most importantly, I guess for this particular conversation is that more than 25% of those engaging with Amy have already taken up services to date. So those are not just numbers, they are signals of real movement. And we can see that behind each of these figures is a story of change where we shift where there's a shift in understanding, shift in agency, as well as shifts in power. We've spoken about choice a lot in this conversation, in this conference, but I just want to close off with the quote from a young person who said her boyfriend refused to do HIV testing. She said, "He won't listen even if I try, so why should I bother?" 2 conversations later, with new knowledge and confidence, she told Amy, "I'll convince him to come and test with me tomorrow." So together, these outcomes show the arc we are aiming for where trust leads to change, to action, and action leads to change. Thank you very much.
Thank you so much, Tomba Fikile. And now for our final presentation, we'll invite Gertrude Jobe, not as good, sorry, from the Zimbabwean Ministry of Health and Childcare to speak to the Zimbabwean experience. So welcome.
Thank you so much. And I know I'm standing between you and time. I'll try to fly past some of the slides. Next slide. Looking at Zimbabwe, we have heard already is an early adopter of the Lenacapavir, and we started preparations maybe starting from September. Already, we are the 3rd country in Africa to have actually approved Lenacapavir. And already 5 days after the approval, our Honorable Minister of Health and Childcare had a press conference talking about the Lenacapavir. And we had so many media houses where they actually looked at what is Lenacapavir. And some of them, they couldn't even explain to pronounce Lenacapavir. So they are actually going ahead now to us telling them what it is. And as a country already, with the approval in the Ministry of Health press conference, we have identified 40 sites. Within those 40 sites, we've actually done site readiness assessment, and we've completed. We've done trainer of trainers as well, and we are actually ready to implement Lenacapavir when it comes. The doses haven't actually come. We are looking at in January that we are getting the doses. And we've got 46,500 people who are actually going to be individuals who are earmarked for Lenacapavir. Next slide. This slide comes from our Zimbabwe Demographic Health Service health survey, which showed in 2024 that as much as we started PrEP in 2018, we still have got awareness is still very low. As you can see from the slide, it's below 50%. And if you look at the ages, the ones who are at high risk of getting HIV, they are actually the lowest. So we need to come up with innovative strategies to actually expand and improve the knowledge awareness on pre-exposure prophylaxis. We've already come up with our communication strategy long time ago, but I think we need to look at innovative strategies which are cost effective with high coverage and rapid expansion. And we are looking at the digitalized tools to actually expand and meet the PrEP demand needs of our population. Next slide. Already, we are working with one of our partners, which is Center for Sexual Health and AIDS Research Center, which we call SESHA, where we've started what we say our innovative challenges for digitalization tools, the chatbot, and we called our chatbot Bimbai. Bimbai in my language this is a local language. In English, it means a trusted self-care companion. So we are hoping at leveraging on the Bimbai, because already where Bimbai is working, where they are employing Bimbai, it's one of the sites where we're actually going to be putting Lenacapavir in those sites. So Bimbai is an AI-powered digital technology companion developed. Mainly it was for sex workers and women on age of sex work. So we want to expand that as we introduce LEARN to include other populations as well. It gives information on prevention, self-testing, and mental health on that. We have already translated Bibai into English to show in our Shona language and in Isindebele. We launched it in September 2025, and from there, next slide. In September 25, that's when we launched Bimbai. Next slide. The next slide is actually talking to say Bimbai is not working alone. We've got even physical posters where we display at clinics, at public health institutions in Gweru there. It has got a phone number because we said we are leveraging on the WhatsApp where the people they work go in, get into that phone number, get into the chatbot, and we have got a QR code as well for instant boarding and other messages as well. Next slide. What we have results from Bimbai so far from September 25 to 28 November, we have realized that sent messages from Bimbai, as you can see from there, and you have to accept terms of conditions of Bimbai. We have seen that 92% have already accepted that, at least one version of the project's terms and conditions. And then engagement with the product, almost about 53% of the users who have started AI companion conversation and sent at least 2 messages or started even an HIV self-test messages. And then we look at that matched engagement target, almost about, I think it's almost what Ntombi Figile presented, where it's about 39%, she had around 37%, who have already used, uploaded a photo of HIV self-test, sent a message to the nurse as well, because the nurses who are working there, 2 hours, they get about 2 hours of their time to look at the chatbot and answer the queries. And we feel it's actually not enough because these nurses will actually be doing other work as well. They have provided enough information to get an HIV risk score. The questions which are there, they actually get you. So what have been the lessons which you have learned within the 2 months who have been employing, looking at Bimbai? We need to co-design important messages for community concerns, because some of them, they were saying the language is not very clear and all that. So we need actually to have the end user in mind when we are designing the messages or translating the messages. There has to be strengthened partnership between the government, the implementers and the users, so that we promote ownership and amplify the uptake of our services. Smartphones, we all take it for granted that we've got smartphones, and someone who has a smartphone, he has got a WhatsApp, and someone who has got a WhatsApp, he has got data on that WhatsApp. I think this, we've learned it even here when we thought we can translate into French and the internet is working, but we had some challenges. So same applies to the smartphones. We need to look at it to say how best can we improve on that? Who should be paying the data? And then the demand for virtual clinical engagement, we've realized there are some challenges, especially when the same nurse is 24 hours working and then the same nurse is supposed to be looking at the chatbot. So for our LEARN, what have been our next steps? We are working very hard with Sesha together because it's our implementing agent, and looking at even where they are, we are going to be implementing LEARN. So we need active engagement. We need even to strengthen on men's sexual reproductive health, HIV and STI, because we've realized 20% of the people who are getting into Bimbai, some of them are men, and we don't even have a male persona in that application. So we need actually to look at that. Nudge for appointments. We've been complaining about continuation of our PrEP and all that. We've realized what we've developed so far on that, it's not actually looking at how can I nudge that person or say come for appointments and all that, or come for services and all that. We are looking at how best we can look at that. We have said this Bimbai is for users, but we need actually Bimbai for the health workers as well, so that they get a lot of information. We all assume that the health workers they have, but we feel that health workers, they should actually be kept abreast. We need to expand not only in Gweru, one of our districts there, but even to other diverse populations. We need to ensure as well the interoperability within the Ministry of Health digital health systems, which are already there, and maintain compliance with the Zimbabwe data collection laws. We are already working with our pro-trust in Zimbabwe to see that Bimbai is in line with the local data protection laws. So I would like to acknowledge everyone who is there and everyone who has actually assisted us in coming up with our activities for the production of Lenacapavir. Thank you.
Thank you so much, Gertrude. We have minutes for a few questions. All right, a lot of questions. This is great. We'll start in the front here, then we'll go there. We'll go to Tapiwa and Hasina, this group. Thank you.
Oh, yes. Thank you very much. My name is Tembisile Kulu. I'm the CEO of the South African National AIDS Council. Thank you, Gertrude and Ntombi. My question is still for Zambia, though. Zambia, very interesting presentation. Can I ask, you mentioned the doses you received from PEPFAR as well as the doses you received from Global Fund. Are those sufficient for the need that the country has? And have the targets that you set been based on the need or just on the doses you've received? I hope that makes sense, because I think modeling has shown us that we need a certain number of coverage in order for us to eliminate disease. And then lastly, what guided the initial set of patients that are due to receive lenacapavir? And I say this knowing that we've got modeling, we've got clinical trials, but don't quote me personally, I still think that it might be a political decision. So what made you choose that these are the first populations that are going to get it? And then lastly for Ntombi, just a few legal and liability questions. On the AI models, who takes responsibility for the errors? Is it the doctor, the platform, the AI developer? And then please say something on telemedicine practice and malpractice, because I think the standards of care around virtual consultations are still evolving. Thank you.
Thank you. We'll take the questions and then we'll have the panelists respond. So just right there.
Thank you so much. My name is Zodwa, and I'm the Director of Health at Elma Philanthropies. My questions are for the AI speakers, which is Ntombi and Gertrude. And I just wanted to hear a little bit more about data safety / privacy on these platforms. How much time are you spending thinking about that, and what do you have in place? And then about, secondly, ongoing costs that are associated with running such platforms. Can you speak to us about what they are and who is covering them? Thank you.
Thank you, Zodwa. Tapiwa.
No, thank you, Zach. Once again, good morning, everybody. My name is Dr. Tapiwa Tarumbiswa, Head of the HIV Program, Minister of Health, Lesotho. I want to start off by saying a big thank you to my colleagues for outstanding presentations. My question is to Mayor Ntombi Fikile. I hope I did not murder it. From Shout Out. South Africa is a multilingual country. In Lesotho, our experience with AI apps is such that we developed it, but then when we needed to translate the Sotho, it gets mixed up with Pedi, Setswana, and also Sotho. Did you guys experience that? Why I ask is because we've had that headache and we could learn quite a lot from you on that. Secondly, the app you're using, is it open source or it's something that's proprietary? Why I ask this is because as we move forward in this funding landscape that's reducing, there's opportunities for countries to collaborate and share some of these tools. It doesn't make sense if we keep developing things everywhere, using so much money, and yet you've done so wonderfully well in South Africa. So those are my two questions. Thank you.
Thanks, Dr. Tapiwa. And lastly, Hasina, right there.
Good morning and congratulations to Swaziland and Zambia for starting Lenacapavir. I'm Hasina Subida from South Africa. My question is to the two AI presenters, is to actually look at, we're talking about not only about PrEP, not only about LEN, and not only about oral PrEP. We're talking about HIV prevention. Do your AI platforms assist people to make a choice in terms of HIV prevention interventions or other prevention interventions? And how do they lead them to the services that they would require? The second issue that I want to just check is in terms of, and this is specifically to you, Ntombi Fikele, about the privacy. And, how do people identify on the platform? And do they need to give consent for their information to be shared with the healthcare provider? And how do you manage that process, especially in terms of the test results? I think that for me is quite important. And then to go back to the earlier presentations, just to ask Zambia, you mentioned that you have your community health workers. It is a possibility for them to introduce